these details, what type of cancer it was, what age they got the cancer, are so important to you. And so this holiday, I really want people to ask, this is about you. This is about your health, because it will change what your doctor says you should be doing.
You've got everybody together. You know, there's no better time to ask than to kind of get your family history together so you know what kinds of things you should be looking out for. This episode was brought to you by Alloy Health and Rivian. And so today, this is why I'm so excited. I'm here with Dr. Trisha Pasricha, a Harvard-trained gastroenterologist and gut-brain researcher who's helping us understand the science of what we can do to feel better and stay healthy. Welcome to the Second Opinion, Dr. Pasricha.
Thank you so much for having me, Dr. Sharon. I'm delighted to be here.
Today's conversation really hits close to home for me because, I have a strong family of colon cancer. My mother died at 57, and my sister was diagnosed with stage 3 colon cancer at 63. Now, the good news is that my sister is still alive and well and thriving, but my mother was not so fortunate. She was diagnosed with stage 4 colon cancer. But those life experiences have really kept me laser focused on how we talk about gastrointestinal health, and particularly for women in midlife. And so beyond the discomfort issues that signal deeper problems, and I can attest to those personally as well. I think for Black women, disparities in colon cancer screening and diagnosis mean that we have to be really vigilant and more informed about how to screen. And, there is an old saw in medicine where, when you're a med student, you sort of pick the specialty based on the bodily fluid you can tolerate. And I must admit, yours would probably fall below the scale of where most of us are. So can you tell me, how did you even get interested in gastroenterology?
Yeah. So you're not wrong. The other way that med students pick their specialty is often based on the personalities of the doctors that they want to emulate. And when I was a med student, I found that the funniest doctors were the gastroenterologists. They could take anything that came their way, and they did. It's like we're talking about bodily fluids. They could take it, but they also had just such an unflappable sense of humor. I loved it. I'll also say that I was heavily biased because my father's a gastroenterologist. And so he grew up, and he's a researcher just like I am. And I have never met anyone who loves their work more than he does. And he has spent most of his career trying to understand these disorders of gut-brain interaction, like irritable bowel syndrome, gastroparesis, things like that. And so, I didn't necessarily want to be just like him when I was growing up, but the more I came to learn about gastroenterology and just see what this whole community was like, I loved it. And I have to say, I love also talking to women. Gastroenterology is pretty heavily male skewed. About more than 80% of practicing gastroenterologists are men. For the kinds of patients I see, most of them are women. It's really nice to be able to say, I get it. I'm going through a lot of what you're going through. And people, women especially, are often more comfortable confiding in a female doctor. They like getting their colonoscopies more often by a female doctor if they can. So that's a need that I think more and more women need to fill. And so I was glad to kind of step in and kind of join that community of women GI doctors, the few, the proud. But we're growing, more and more of our trainees are women. So I've really enjoyed it. And you really can't embarrass me in the next hour. There's nothing we can talk about that I haven't talked about already today.
Well, you know what? And that makes two of us. I'm very rarely embarrassed by anything anybody says. But you have a subspecialty of a subspecialty, and it's neurogastroenterology. Is that right?
That's right. Yeah, it's a subspecialty that people haven't heard of. Everyone has sort of heard of the gut-brain connection. That's like a buzz term that's been thrown out there. And we all know intuitively what that is. We have felt maybe it's butterflies in our stomach when we're nervous, or maybe we've had to go to the bathroom right before our turn at karaoke. We've felt the day-to-day consequences of the gut-brain connection, but there is in fact a whole academic field devoted to it, and that is called neurogastroenterology. So it's an extra year of training and a lot of different procedures that you learn that are specific to this subspecialty, but it's really trying to understand a lot of different diseases that we know affect the enteric nervous system. That's a nervous system that runs through our guts. It's a system of neurons, just like the one we have in the brain, but it's not limited to GI diseases. So for example, I have an NIH grant to study Parkinson's disease. A lot of people don't think of Parkinson's disease as a disease of the gut, right? But what I study is how, for a subset of patients, that could begin. Parkinson's disease might originate in the gut, and how can we detect it early before it hits the brain? So it's a lot of different kinds of diseases that we study, but it really can apply to a lot of different kinds of people.
So all in, how many years are you after medical school, after you've done?
Oh no. Yeah.
Let's see. How many years?
A lot. Meds, it's a lot, right? It was 3 years of internal medicine training, 3 years of GI training, 1 year of neurogastroenterology. I did a master's of public health for funsies. So altogether, we're talking like we're getting on 6, 7, 8, all close to 10 years.
I want all of my listeners to understand that when it comes to second opinion, we do not skimp on the experts. I wanted you to say that. So you knew that we are coming to this from a standpoint of real, true knowledge and experience. And, and you touched on something earlier that, I remember from med school, and we talked about that mind-gut connection. And, and we, just like you said before, we understand it without really understanding it, in the sense that it's already in our language. We say, trust your gut, or
right.
I can feel it. What does your gut say? Because there is this entire other nervous system that everybody knows your brain, that's your central nervous system, and your spinal cord and nerves. But people don't really understand that we have this whole other nervous system throughout our entire GI tract. So tell people a little bit about, what does that enteric nervous system do?
That's absolutely right. So the enteric nervous system, it's this network of nerves. And evolutionarily speaking, organisms had an enteric nervous system before they had a central nervous system or the brain. So it's really been around for a long, long time. Like if you think about, for example, this cnidarian group of animals, which is jellyfish. If you picture a jellyfish, you don't see a brain. You see this like translucent head. Where's the brain in that animal? And yet that animal, it's floating around. It's making decisions about swimming, about where to find food, if there's a predator. It's doing that because of its enteric nervous system. So the enteric nervous system started out as this way to process nutrients, to eat, to digest. But it's actually become much more nuanced and complex than that. So in our case, in humans' case, it's connected to the brain via the vagus nerve. So the vagus nerve is this long nerve that descends from the brain. It's probably the most important highway that communicates between the enteric nervous system and the brain. It's a two-way street. So I think we often think about how much the brain influences our guts. Like when we're nervous, we start to feel a little sick. We have a gut feeling. But 90% of that communication between the gut and the brain goes in the other direction. It goes from the gut to the brain. So the gut is taking all of this information from the food we're eating, from everything from our outside environment entering our bodies, and it's sending signals up to the brain about how we should react, how we should process. And I would say in the last at least 20 or so years, we're really understanding how and why it is that what we eat and what we put into our bodies can so strongly influence our mood. It can influence our anxiety, our depression, and it can influence these big neurodegenerative diseases like Parkinson's and Alzheimer's. And so it's a really exciting area of study. One of the reasons I decided to become not just a physician, but a scientist was actually because a lot of my patients that I saw when I was a med student, they had irritable bowel syndrome or some kind of, quote, disorder of gut-brain interaction. These predominantly affect women. And a lot of times these women would get studies, colonoscopies, upper endoscopies, GI tests, because they had really horrible GI symptoms. And all those tests would come back negative. Like we'd get biopsies and they're all negative. That's the sort of the hallmark of irritable bowel syndrome. The problem is that when that happens, women start to get told that their symptoms, their gut symptoms, they're all in their head. And that is the way that I think people thought about the gut-brain connection for decades. Since the 1800s, people were thinking about it all is top down. And if only we could, cure your depression, if only you would de-stress, then maybe your gut symptoms would go away. We certainly know that people who have chronic GI symptoms have depression, anxiety. Who wouldn't? But what I wanted to do as a scientist was understand, what is it that's happening at the gut that we're just not seeing with the tests that we're doing?
we're going to talk about a lot of stuff. We got a lot to cover. So this is something that has been in the news. I want to hear about it because people hear it, but they don't really know what it means. And there is what is called the GI microbiome.
Oh, yes.
And its role in regulating gut health. So explain to everyone, what exactly is the microbiome?
Great question. Very common question. So our microbiome, this may or may not come as a shock to anyone, but we are living with trillions of microbes in our bodies, and they colonize our guts. They are in our mouths. They're actually all over our skin as well. Like your skin has a microbiome, and the microbiome is referring to all those microbes and their genetic material. Together, we call that the microbiome. And the microbiome, we live in what should be a very close and happy harmony with all of these bacteria. What people sometimes hear in the news are that there's good bacteria and there's bad bacteria. And we're going to talk a little bit about what all that means. And then when you have this conversation about the microbiome, you often start to hear words like probiotic and prebiotic and even postbiotic thrown around. And very quickly you're in this like linguistic quagmire and you don't really know what all of these things mean. But I'll break it down very simply and say that for me, the easiest analogy I usually make to my patients is that the microbiome is like a garden. Okay, and so in this garden, you can have lots of flowers grow and occasionally weeds might grow as well. And sometimes in the news, I think we oversimplify and say, okay, well, the good bacteria are the flowers and the bad bacteria, they're the weeds. And maybe if we take a probiotic, like, so we can throw seeds of the kinds of flowers we want to grow in there. That's what the probiotics are hoping to achieve. Then maybe those will grow and flourish and the weeds will die away. The problem is that, like with any garden, sometimes what's growing is not just because of the seeds that you planted. Sometimes it's because of the soil. Sometimes it's because of the sunlight. Sometimes it's because of the other conditions. And maybe what's growing is not the problem, but is the result of the problem further back, right? And so we do have these bacteria that we know are associated with certain disease states. But I actually usually never use words like good or bad bacteria because I don't know. I think most scientists don't know definitively, for most cases, whether the bacteria that we're seeing are really bad, or are they just growing because that's what the natural environment is supporting them to do? And what's bad, or what is the problem, is something much further upstream. So, for example, a lot of people may have heard in the news about this bacteria called Akkermansia. Akkermansia is in the news a lot. It's thought that
I haven't heard of Akkermansia, so please enlighten us.
People seem to think that it's associated with a lot of metabolic diseases. And if only we had more Akkermansia, then maybe those metabolic diseases like diabetes or obesity might be improved. And a lot of probiotics seem to target that bacteria. And that's fine unless you start to dig a little bit deeper. And then you find that people with Parkinson's disease, they have a lot of Akkermansia in their microbiome. So suddenly, if we start to give you a lot of probiotics that contain this so-called good bacteria, are we actually doing the right thing? Do we actually understand what's causing it? And that's one good example of a paradox in there that seemed to be a great bacteria until you start to look at all of the diseases that it's underrepresented. And so sometimes when people talk about the microbiome and they're trying to say, oh, should I take a probiotic? Should I do a fecal transplant? Those are very popular.
Oh, let's do this for a moment because that is fascinating to me. One of the theories is about how is our microbiome established? Okay, so we've got these trillions of bacteria and fungi and viruses and all these things that do all these wonderful things in your gut. Well, how do they get there? How do so how does it get there in the first place? And one theory, this is one theory that I heard, is that the reason why there are so many GI issues in people is because of the rise in C-sections. Is that babies, when they are born, they pass through the mother's vagina and it has its own microbiome and things that are fluids that are swallowed and the baby is exposed to in the process of being born. And when you circumvent that process and have a C-section, then that baby never gets populated with those particular type of bacteria. So what do you think about that? I'd like to your take.
It's not wrong, actually. So there is some what we know about the microbiome is that it's influenced by a lot of different factors, especially our earliest years of life. So this question about vaginal deliveries versus C-section has been really well studied. It is considered one of the most important factors in what happens initially to your microbiome. So this has been studied. And they've also done these studies to show that the microbiome is very different when you travel through the vaginal canal, at least initially. But what I want people who are listening to this to just know is that this doesn't mean that you should or shouldn't get a C-section based on what is going to happen to the microbiome. Like, you should do it for what is right for your health and your child's health in that moment of delivery, right? And there's no sort of shaming about what the right decision is at the time. Like, I never want that to be the discussion. And similarly, like, there's a lot of discussion in the microbiome world about breastfed children versus formula-fed children, how that can shape the early microbiome. All of these those factors are not the factors that I worry about with my kids and worry about when I counsel other people, because those two decisions are made for the right reasons at the right time, right? And so, but I will say that the science behind them shaping the microbiome, it's there. But what are the other things that happen in our childhood that shape the microbiome? Because those years 0 through 5 are when our microbiomes are most malleable. After that, we sort of settle into this pattern. It becomes difficult to change our microbiome unless we make big dietary changes, which we should be doing. But what tends to influence the microbiome beyond those two things, how you're born, like what method of delivery, and then maybe were you breastfed or bottle fed, there are things like whether you have animals in the house. Like, do you have a family dog? That plays a big role. Are there plants in the house? Are you exposed to farm animals in particular? Like, kids who grow up on farms, their microbiomes look very different than others. And then what kinds of foods are you eating once you start eating solid foods as children? Like, are you exposed early to fruits and vegetables, whole grains, whole foods? So those things, I think, play a really big role in setting you up for success later on. That, the conversation about like the C-section and the vaginal delivery, often when we're having that conversation, it's like a little too late for anyone to do anything about it. And that's like not the thing that I want anyone to focus on.
Well, I think that you're right. And one of the things that comes to my mind when you're saying that early environment, particularly, is how much we use antibiotics in children.
Totally.
Children get antibiotics for everything. And, and I can say this, let me just say, I'm the youngest of 8 kids, and I didn't get a course of antibiotics, I don't think, I don't know, until I was 5. I had tonsillitis.
Oh, no.
By contrast, my children, by the time they were 5 or 6 years old, between ear infections and this, and you have a fever and you get here, and they had multiple courses of antibiotics, which oftentimes are not necessary, but, that's what we do in today's world. Are pediatricians sort of aware of that? I mean, because it seems to be that there's always sort of that knee-jerk reaction to respond to everything with a course of antibiotics.
Yeah, you've hit on a big tension in the microbiome world, which is, I think a lot of pediatricians are quite aware of this data. And I think pediatricians are even maybe more worried about microbial resistance. And so they're trying to be good stewards. I have to say, I think the problem is us parents oftentimes. Like, we push our pediatricians. We're like, oh, but our kid's sick. They're getting kicked out of daycare. You have to give them something, and like, I think we push often. And sometimes that can be really tough. I think when it's appropriate, when it's a bacterial infection, we should give our kids antibiotics appropriately. It's those cases where it's a gray zone. We're not really, this could be a virus that I think we're making a little bit of we're over prescribing.
Right.
From adults, I often hear a big worry that adults say, like, I took some antibiotic. I'm like worried this is going to throw off my microbiome. Maybe I'll take a probiotic, or like, I'm really worried about it. And I will say the good news about being an adult, the good and bad news about our adult microbiome is that we're very resilient. People's microbiomes as adults tend to bounce back to exactly where they were before within about 3 weeks. So it's actually pretty rare for someone to completely throw off their microbiome in a long-term way because of antibiotics as an adult.
I want to get back to the issue about the microbiome because it's so important. Okay, so it's established. But once your microbiome is screwed up for whatever reason, all right, and you're having symptoms as a result of it, how do you correct it?
Yes. Well, I will say, if you're having symptoms, you should always go see a doctor. Like, I think people should have a low threshold to chat with their physician, because I think sometimes we're quick to say, this has got to be a microbiome problem. And just remember, the microbiome, enteric nervous system, vagus nerve, central nervous system. All of these things are pieces of a whole. And so sometimes just focusing on the microbiome, we can miss other areas where we can help and intervene. So I think always see a doctor if you're having symptoms. However, the best way to change your microbiome as an adult is through your diet. That's not going to a change that will happen overnight, but it is a change that can be sustainable and can happen over the course of like 8 to 10 weeks is what studies have shown if you stick with a dietary change. And the healthiest thing that you want to do for your microbiome is feed that microbiome prebiotics and probiotics. So prebiotics means food that your microbiome, those bacteria like to feed off of. And typically we're talking about high fiber foods, like whole grains, fruits and vegetables. Probiotics, when we say that word, I think a lot of people immediately think of like the supplements that comes in a capsule. What it originally is supposed to mean are like live bacteria. The pro meaning life. We're talking about live bacteria. And what I'm talking about are like any foods that are either fermented or that have live culture. So like Greek yogurt is a good example of that. But fermented foods like kimchi, sauerkraut, soy sauce, sourdough bread is a good example. So there's more to fermented food. And studies have shown that if you start introducing these foods, you can change what your microbiome looks like within 2 to 3 months. And the reason I say change is because my guess is most listeners right now are not meeting the requirements for high fiber intake. And that's true for about 95% of Americans. We are not eating enough fiber. And that's partially because most of our calories, like 60% of our calories are coming from ultra processed foods, notoriously low fiber. But if you're feeling ill, often the first thing I say to do is, let's try just cutting out the ultra processed foods, and cutting that out is one step. What are you going to replace it with is like an even more important part of that conversation. And start introducing slowly but surely more high fiber foods to your diet. It is true. When people eat fiber, that you're going to feel more bloated initially. You actually it might not sit so well with you in those first week or two. You want to stick with it. And you want to go slowly. I always tell people, don't suddenly eat a ton of fiber in one day if you're not used to it, right? Like your body will not respond.
I took a big thing of flaxseed one time and I thought I was going to die. I was like, good Lord Almighty. I was, okay, all right, I get it now. Go slow on that. Every Thanksgiving, my family and I pile into the car and head to my sister's house down south. It's a tradition that's as much about the drive as it is the turkey. We sing along to our favorite playlists and share stories about years past. When our kids were small, we could pile them all in the backseat of the car and take a road trip to spend Thanksgiving with family. When you have little people, you can put them all in one room. Now we have grown-ups and significant others, and that plan no longer works. This year, we're traveling to meet our newest family member, the first baby of the next generation. But this time, we need more room. That's why we booked a stay on Airbnb. Thanksgiving is the only holiday devoted to family, food, and the warmth of homes. And thanks to Airbnb, we'll have a beautiful home to make more memories and welcome our new nephew. As I look around at my family laughing in the car, I often think, while we're away making these memories, someone else could be creating their own special holiday traditions in my home. That's what I love about hosting on Airbnb. Your home doesn't have to sit empty. By opening up your extra space, you could turn it into a welcoming retreat for travelers from around the world, giving them a place to gather, cook, and make lasting memories of their own. And the added income? It could help fund future adventures, thoughtful gifts, or whatever else matters to you. Wouldn't it feel good to know your home is helping create holiday memories for other families? Your home might be worth more than you think. Find out how much at airbnb.com/host. This episode is brought to you by our friends at Rivian and their all-electric, full-size SUVs and trucks made for all of life's adventures. Rivian just announced their all-new Rivian Quad, their fastest, most capable vehicle yet. Powered by 4 motors, one for each wheel, it gives you unmatched traction, control, and performance anywhere you are. On winding roads or off-road trails, the Quad is engineered for precision driving and maximum adventure. With a native NACS port, the Quad is compatible with 50,000 DC fast chargers, so getting back on the road is hassle-free. With beautifully designed interiors, tons of storage, and incredible capability inside and out, the Quad is made for everyday comfort and rugged utility. Plus, you'll love the tech. The Rivian experience gets better over time with software updates. The premium audio experience sounds as good as the ride feels. Premium audio is part of the Sound Plus Vision package in Quad and Tri vehicles and can be a paid upgrade in dual models. And the Rivian Autonomy Platform Plus, a paid subscription product, offers a full suite of advanced safety and driver assistance features. There is adaptive cruise control, active lane keeping, blind spot monitoring, and forward collision warning with automatic emergency braking. Check out the all-new, all-electric quad truck or SUV and the full lineup of vehicles now at Rivian.com. What I want everyone to know is, what does the microbiome do? What is the communication? What is it regulating in your gut, and why is it so important? Aside from just symptoms, what does your microbiome do?
So that gets to this next question of postbiotics. So postbiotics are all of the compounds, the chemicals, the molecules that your microbiome is producing every day. And so people may have heard this term, short chain fatty acids. These are compounds like...
They haven't. They haven't.
Fair enough.
Okay, go ahead.
So one beneficial compound that our gut microbiome can produce are called short chain fatty acids. And one example of that is butyrate. Butyrate is a really beneficial compound that can help with your heart health. It can help lower the risk of cancer. All of these short chain fatty acids are produced in different amounts depending on the composition of your microbiome, depending on which species tend to be more predominant. Some make more of these, some make less of these. What we want to do is ultimately try to skew our microbiome to producing these, because these short chain fatty acids, and there's lots of other compounds in this postbiotic world, they influence pain perception. So people who have increased amounts of certain short chain fatty acids, they tend to feel less pain. And so that's why often fiber, simply psyllium husk fiber, is used as a treatment for irritable bowel syndrome, because not only does it help with the kind of consistency of your poop, which is great, but it actually does change how pain signaling and pain is processed, starting from the gut up to the brain. So they do a number of different things beyond just how often you poop, how soft it is, but they really do influence your whole body's health.
You know, so many women complain of bloating. But the bloating thing even starts earlier than midlife, because all of us who have had periods at some point in our lives understand that there is clearly a hormonal component to how your gut is functioning, whether or not you feel bloated. You feel different when you're premenstrual than you do afterwards. And so what is that connection between hormones, our hormones that we make as women, and how our gut is responding?
Yes. Big question. So, let's start earlier in the cycle and we'll move forward. No pun intended with cycle, but so periods. It's so common, at least 1 in 4. Some studies say 1 in 3. Women have changes to their bowel habits during their period, right? And I have the patients who come to see me, say the funniest things, to describe what those bowel movements look like during their periods, but it's not pretty, right? Often we have really, really bad diarrhea for part of it. Sometimes we're really, really constipated leading up to it. And that partly is related to hormones. So progesterone is known to slow down the motility of your colon. It slows down how things are moving, and that varies with your cycle. And the other thing that happens just as your period is starting, as you know, is we get this surge in prostaglandins. So prostaglandins, which help with the kind of uterus to contract and shed the lining. Well, prostaglandins also play a role in how quickly your colon is squeezing things along. And so people who have been experiencing during part of their cycle just rising constipation, suddenly they might feel wait, suddenly I'm having this horrible diarrhea. It's swung in the other direction. That's related to the prostaglandin release. And then the whole thing kind of starts all over again. And it can feel like it's hard to get a hold of what's happening. It's also why in pregnancy, people tend to get a little bit more constipated, or a lot more constipated as things go on, is that progesterone part of it, because it slows things down.
And then those common GI issues tend to increase in perimenopause and menopause. Now, so what do you think is the reason for that? Number one, I have two questions.
Yeah.
What is the reason for that? And two, what can we do about it? Because, as you said, they come in and they're complaining of all these things they never had before, even food intolerances that they, for whatever reason, never had a problem with onions, never had a problem with milk. And now clearly something's happening. So explain to us what is going on in midlife.
Let's talk about it all. Let's start with bloating. Okay. So bloating is something that you're right. I think a lot of younger women are familiar with, especially related to their period. Several things happen in midlife though, can happen in midlife that I think can bring on bloating for the first time. And you're like, wait, why is this happening? I never had this before. So one, lactose intolerance. Suddenly that can show up in your 30s, 40s, 50s, and you are just completely fine drinking milk the rest of your life. And suddenly you start to feel bloated all the time. Often I ask people about lactose. Like I say, try cutting out dairy for 1 week. And they're like, no, I drink dairy just fine. That's never been an issue. Surprise. That enzyme that breaks down dairy products can disappear at any point as we get older. And that's normal. That enzyme will disappear for most people. And that's considered, within the range of normal. But you have to think about it. Celiac disease is a big cause of bloating that can also happen midlife.
Okay, we're going to bookmark that because I want to come back to that in just a minute. Okay, yes, go ahead.
So celiac disease, we often think about a lot of autoimmune conditions like inflammatory, and this is in my world, inflammatory bowel disease, celiac disease as being something that gets diagnosed in their late teenage years, in someone's 20s, maybe even early 30s. Right. There's often like another peak that happens later in life of these diagnoses. Yeah. So if someone has new GI symptoms, I want to think afresh about all of these other things that this could be, knowing that a lot of diseases do show up for the first time a little bit older in life.
And let me just stop for a minute so our listeners understand what is celiac disease. And it is a gluten intolerance. It's sort of, for whatever reason, you're not digesting gluten.
So that's one of those other things that can cause bloating. It actually can cause diarrhea. It can cause constipation, and make you feel ill. And unless you systematically try to look for it, and you wouldn't, because you would say, well, most of my life, I've eaten these foods just fine. Why now? There are a lot of hypotheses when it comes to new food intolerances, gluten being one of them. You mentioned some big ones, onions, garlic, why these can crop up later when they didn't seem to be such an issue before. We don't know is the short answer yet. We do know that for some people, there is a clear-cut trigger. Like a story I hear often in my clinic is someone will say I had this episode of gastroenteritis. I got food poisoning one time. I've never been the same since. My gut has never behaved the same since. Afterwards, I couldn't eat onions and garlic anymore. Afterwards, I kind of had diarrhea ever since, or loose stools. And we think it's that viral trigger that causes a little bit of damage, a little bit of scarring to the enteric nervous system. But it's a little bit hypothetical. But if someone has new bloating, I want to think about, is it a food intolerance? Maybe it's lactose, maybe it's something else, maybe it's gluten. This is not the most common cause of bloating, but I always make a real big point to emphasize this, and I know you'll appreciate this. In a postmenopausal woman who comes to me and says, I have new bloating, I wake up with it. It's not related to eating. The first thing on my mind is, let's make sure we are not missing ovarian cancer. Right?
Exactly.
Ovarian cancer, it's not the most common cause of bloating. 1 in 3 women go to their primary care doctor for bloating. So this is a very common symptom, but if this is new, if you're postmenopausal, we should not miss it, because people delay getting care for bloating. We brush it off as no big deal. We brush off so many GI symptoms as no big deal. That's why I keep saying, have a low threshold to just run things by your doctor. But the later we think about it, the later we might catch the disease. And I want to catch this early.
And I have that on my list of things to talk about, because I think it's really important, because of the fact that ovarian cancer is so vague, and we don't have a screening test for it. And we tell patients, oh, well, look out for unexplained bloating. But I think that it's really important. It's not just the bloating. It's, as you said, it's the pattern of bloating.
Right.
That, new onset. Is it persistent? Is it not in relationship to something you ate? And does it not go away?
Yes.
Because I think that that's sort of, if you had onions and now you're bloated, I don't think you have ovarian cancer. But by the same token, keeping track of what precipitated said bloating. Like don't go eat a whole pack of flaxseed like I did, because that will certainly do it to you. Don't do that. But it helps because when you go to see your doctor and you're trying to explain what your issues are, knowing the pattern and what happened prior to the bloating is really important. I believe some people have gluten intolerance, but I think a lot of people don't have gluten intolerance. And and there is this whole, because now there's a market.
A lot of people who have, I think you probably should never self-diagnose gluten intolerance without talking to a registered dietitian, because so many people who think they have gluten intolerance might actually have something else called fructans intolerance, or they might be intolerant to something else that is making their way into their diet at the same time that they're eating that gluten-containing food. Like, for example, I've had patients who are like, think that they're gluten intolerant, and I'm like, okay, well, what are you eating that makes you ill? And it's spaghetti, and I'm like, you know what? It's the red sauce. It's the red sauce, the tomatoes that are all like common triggers of reflux, that contain the garlic, that contain the onions. And if they actually just cut the red sauce out, suddenly they were able to eat spaghetti again. And I'm going to say, you know what? You could be one of those people, but why don't we get you to a registered dietitian so that you're not just cutting out lots of foods that maybe you don't have to, that maybe you could tolerate? Because that's the part that scares me, is when people just start cutting out more and more and more and more, and suddenly they're not eating all the foods that actually probably they would have been able to tolerate.
The one thing that we must talk about, and that is colon cancer.
Yes,
and
please.
As I said, that's my family history. I make sure that I get my colonoscopies early and often.
Thank you.
But we're seeing something that's really disturbing, and that is a rise in colon cancer in younger adults. And is always the case, no matter what you're diagnosing. There is also a disparate outcomes in African Americans who are diagnosed with colon cancer. So let's talk about that. What do you think is responsible for this rise in young adults with colon cancer?
It's not even $1 million question. That's $1 billion question. It's like a priceless question. Lots of groups are trying to understand it. I think this is like one of the biggest medical mysteries of our generation, to be honest. We used to think that cancer was genetics and smoking. Right. And we haven't changed our genetics in the last few decades. We've certainly cut down smoking, and yet we're seeing these cases. So we are arriving more and more at the conclusion that this has to be our lifestyle. And so over the last couple of decades, we're learning that what we put into our bodies can be strongly linked specifically to colorectal cancer. Like colorectal cancer, because of that interaction with inflammation in the microbiome, we're really, really susceptible to the kinds of foods that we put in. And so there was actually a study that just came out recently that linked from the Nurses' Health Study, which is this large cohort that I know is a lot of important studies have come from, that linked ultra-processed foods with colorectal cancer. It's not the only risk factor, but it is a big one. We're getting 60% of our calories from ultra-processed foods, but it's other things that we're eating. Sugar-sweetened beverages separate study has shown that not only, in general, we're drinking more of these in our early childhoods and our teenage years. We're drinking more of them since the 1990s, but that is independent of everything else linked to the development of colorectal cancer. Red processed meats, how we're cooking those meats. Are we grilling them? Are we charring them? Those things are linked to cancer as well. And I find this sort of disturbing rise in like the carnivore diet to be pushing us a little bit in the wrong direction there. Alcohol use, I think this was a big one, that we previously, alcohol, we used to be told that drinking a glass or two of wine a day was heart healthy, right? And then the Surgeon General came out with this big warning about the risk of cancer related to alcohol, basically saying that there is no amount of alcohol that is safe when we're talking about cancer. And it turns out that's true for dementia as well. There's no mortality benefit to drinking alcohol, right? And that's hard to hear because we've ingrained this in our culture about drinking wine. It's like part of how we relax and enjoy. So, and same with red meats, like a lot of the dietary changes are really hard to change, but those are the things that seem to be playing an outsized role in colorectal cancer.
I wanted also people to know about colon cancer screening because we are now seeing it in younger adults. We've moved the bar in terms of when we should screen.
Yes. Yes, we've moved it, but I have to say, I think we haven't done a good enough job yet of getting people to actually do the screening, like in that age group. So what you're referring to is that we used to say start screen if you're at average risk, not someone like you who has a family history. You should screen earlier as you are. But usually we said start at age 50. Now we're saying because of this rise in early onset cancers, start at age 45, but only less than 20% of people who are eligible to get their colonoscopy between 45 and 49 have actually done it. So if anyone's listening right now, they're due for their colonoscopy, this is your sign. This is your sign to nudge your spouse and go get that colonoscopy because we're behind in that early onset range. And we really want to catch those early. The earlier we catch any problem. And, what I sometimes think is a conversation that gets a little bit missed is colonoscopies are not there to detect cancer. Right? That we are there to detect polyps. We are there to detect cancer before it happens. So before there's a cancer, there's a type of growth called a polyp. About 5 to 10% of those polyps will go on to become a cancer. So that's why the colonoscopy test, it's a polyp hunt. We're looking for them. We're taking them out so that they never become a problem. The alternative to colonoscopy screening is the stool kit, which is very convenient. I love the stool kits for anyone who can't get the colonoscopy.
That's the doctor or the ones like Cologuard that you have to get.
They come in a box. Poop in it, put the sample in, mail it off. You don't think about it again. Those are great, especially like if there's some reason that you can't get the colonoscopy, but you're not going to detect polyps as well. And you're certainly not going to be able to take them out. And if you have a positive test, meaning there's like a very high likelihood that there is maybe a cancer or some worrisome form of tumor in there, you got to get the colonoscopy anyway. So if you have the ability, it's not always easy for everybody. You have to take half a day off from work, usually get anesthesia. You need a ride home. These are big barriers.
They are.
And we can't undermine that. If you're able to get it, get the colonoscopy. If you can't, by all means, get the stool kit. Like know that the stool kit exists and it's another option.
Okay. And in addition to lowering that, the bar for getting colon cancer screening as with the colonoscopy, we've also changed the interval and which now it's like 10 years. Now, if you ask me, now granted, I have a family history, so that's different. But if you have a family history, instead of 10 years is too long, if you ask me. So how often, if you have a family history, should you repeat your colonoscopy?
Every 5. So we do every 5 years if you have family history. And when you start, depends on the age of that relative, right? So if you start at 45, but say your dad had colon cancer when he was 47, you actually should be getting started when you're 37. And, and also say like the holidays are coming up. It's really important that people talk to their families. Like, I know that's not like everyone's favorite dinner time conversation, but it's so common that I talk to my patients and I'm like, hey, who in the family has colon cancer? And they're like, oh, I don't know. I think, my brother had some GI problem. I'm not sure what it is. Or someone had some cancer. These details, what type of cancer it was, what age they got the cancer are so important to you. And so this holiday, I really want people to ask, this is about you. This is about your health because it will change what your doctor says you should be doing. So it's important to get that information. And about a quarter of these early onset cases of colorectal cancer could have been caught sooner if we had just screened them sooner, according to what they warranted based on their own family history. We just didn't know about it. We just didn't talk about it.
It is important. And we've got Thanksgiving coming up. And I don't know when this show is going to air, but Thanksgiving is Family History Day. I think as designated by, who knows, AARP.
Change the name.
You've got everybody together. You know, there's no better time to ask than to kind of get your family history together so you know what kinds of things you should be looking out for. All right, so I'm going to go. We're getting to the end of our segment. And before you leave, I'm going to give you some rapid fire.
Let's do it.
Gut truths. Let's do it. Okay. All right, so we talked about colon cancer screening, but what about rectal exams? Yes, no. Good thing, bad thing?
Well,
and I say, and preferably done by your doctor. Okay.
It's a separate conversation, Dr. Sharon. But yes, I think rectal exams make sense when you have any kind of symptom that you're worried about. Like, so for example, patients come to me with constipation, certainly people who have rectal bleeding, we're taking a look for hemorrhoids, we're taking a look for fissures. If you have a lot of pain when you're passing a bowel movement, makes total sense to get a rectal exam, makes total sense to ask for a rectal exam.
I used to do them every year on my patients over age 40 because I was like, if you're going to get a colonoscopy every 10 years, how about that? We'll check a little bit in between, but that was me.
And also during a colonoscopy, I mean, we routinely, we're taking a look. And so if you're getting your colonoscopy, someone's going to take a look. But if you're outside of that window and you have anything that you're worried about, please ask.
Okay. Number 2, sodas with probiotics or probiotic drinks. Yes or no?
It's going to be a no from me. Mainly because I think oftentimes those drinks have a lot of sugar. They are like technically ultra processed. I would rather always have a probiotic food. I would rather have low-fat Greek yogurt. I would rather have kimchi. I would rather have sauerkraut than the ultra processed form, because honestly, a lot of the time, well, first of all, there's not great data for those. There's like really good data for the other things. And we don't know what we are calling probiotic in some of these processed forms, if those bacteria are actually still alive or not. Like that's the whole problem. Sometimes what is probiotic, those bacteria that you put in a capsule, they're dead by the time they hit your colon. You're not actually recolonizing anyone.
How about probiotic tablets? You know, I mean, or, you know, the capsules, however they come, the live, and they say probiotic is for gut health. And, you know, we can buy them in the drugstore. Yes, no.
This will come as a shocker to people. Despite what you've heard on social media, most gastroenterologists actually do not recommend probiotics. It is not in our guidelines. In fact, the American Gastroenterological Association does not recommend probiotics for most conditions. We do for certain kinds like pouchitis, which you see in inflammatory bowel disease. That's really specific. The reason for that is not because I'm going to tell the patient in front of me, probiotics never work. They do not work for you. It's because the data is so mixed. So if a patient comes to me and says, I tried one and it changed my life, like I love it, I'm not going to rip it from your hands by any means. But more commonly, what I see is patients coming to me saying like, I had some problem, bloating, constipation. I've been taking a probiotic now for 3 months. And I say, well, do you feel better? And they're like, I don't know. But clearly they're sitting in front of me. It didn't do too much. That's a situation where I say, why don't we look at the data together and see what, you know, whether this really makes sense versus let's change your diet maybe. And let's think about what we can do there.
Yeah. And if you take it and it feels and it works for you, trust your gut, right?
That's good.
All right. Colonics.
Oh my goodness.
Helpful cleanse, or is it a health hazard?
Health hazard. We have this idea. I don't know. Well, I know how it started. It's this Victorian era idea that we are all sitting with toxins in our body, or that we have like lots of stool just kind of sitting there caking the lining of our colon that we need to get rid of. That is not the case. And there's this idea that we need to do these cleanses from time to time. You're going to feel better, feel lighter. That's not, your body is incredibly good at removing toxins on its own. You don't need to manually do that by any means. What you risk doing is perforating your colon. That's rare. Okay. But it's the thing I worry about most. Or introducing something into your colon that doesn't belong there in the first place that can cause trouble.
Yeah, I get it. Because my thing is like, so you would just go someplace and have a stranger do that? I don't get it. But okay, yes. So you and I agree on that. Colonics, perhaps not.
Let's give it a miss. Yeah.
And one thing, because we didn't talk about it and we got to talk about it. Bowel movements. How often?
Ooh. Okay. Again, I'm going to blow your mind, but you don't have to go once a day. Okay. And I'm going to tell you something even better. If you meet your fiber goals. Okay. And so for women, we're talking about 25 grams of fiber a day. When you meet your fiber goals, you're going to poop more often, and you need to embrace that new you. Like you're going to go 2-3 times a day. That's normal, right? This once a day idol that we hold in our minds in America, that's actually not how a lot of the rest of the world lives. You know, like if you look at Europe, if you look at India, like East India, where they eat a very high fiber diet that's mostly vegetarian, going 2 or 3 times a day is the normal. Here, we think going once a day is normal. We think going every other day is normal. It really depends on your diet. It depends on your stress. It depends on your exercise. It depends on if you're traveling, lots of different things. But my short answer to people is, how often do I need to go? The answer is, you should go as often as is comfortable for you and that is socially appropriate. Like, so if you're going 3-4 times a day,
it is socially appropriate. Oh, let me think about that.
You're going
not
3
in the
times
middle of a
day.
party. Don't do
No.
it if you have to. If you can, don't do that. Okay.
Yes,
All right.
yes. Well, I
Okay.
mean, I'm in favor of people like availing themselves in public if they have to, but like, if it's like, I'm not going to go to the party because I'm so afraid of having a bowel movement, that's when I say, okay, maybe we have like an issue here.
You know what? This was such a great conversation, and I want to thank you so much for being here today.
Thank you, Dr. Sharon. This was wonderful.
Now we're reaching the part of our show where I give my doctor's orders. And doctor's order number 1, if you are having GI symptoms, track them. Don't guess. Log your symptoms. When, what, how severe, and what really precipitated the symptoms. And bring that record to your doctor. Don't self-diagnose. Number 2, know the red flags. Blood in stool, unexplained weight loss, persistent pain, or anemia in postmenopausal women deserve immediate attention. And number 3, screen early, not late. Colonoscopy is now recommended at age 45 for the average risk person and earlier if you have a family history. For more information on this episode, check out our show notes. Join us each week wherever you find your podcasts as I break down medical topics and leave you with expert advice. If you enjoyed the show, follow us so you never miss an episode. If you like what you hear, leave a review. You can submit your questions at drsharonmalone.com and click on the second opinion. Until next week, take care.